And welcome to the Deuk Spine Institute. It is the 13th of July. We are on our last surgery for the day. Our patient comes from California. He traveled here for pain that he's been having in his neck and lower back. We've treated his lower back partially. We've done surgery. He had Deuk laser disc repair shot at L4, L1-2, L2-3, L3-4, L4-5 shot. That it right there? That's it?
Yes, sir.
So he's had surgery already in his lower back, and he also has had surgery in his neck, as many of you can actually see in this picture. Can you see the x-ray there, Henry?
Yes, we do.
And what we're seeing, folks, is you're seeing metal plates in his neck, which I did not put there. They were put there by another surgeon. And he's had fusion there. Okay? Shot. Shot. So now he presents with adjacent segment disease. Specifically, that looks really good. If I can get to the bone. Shot. So I'm targeting the lateral mass. And I'm struggling a little bit with his fascia. Shot. That should be good. Shot. So, because he's had a fusion, he now has what's called adjacent segment disease. Shot. And that adjacent segment disease is what's causing his symptoms. Shot. Shot. I'm just feeling around at this point on his spine. Shot. I'm trying to find the perfect spot to go in and burn the pain nerves. Shot. 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 All right, so shot. And before I do anything, any kind of deadening of nerves, I want to make sure, there we go. That feels good right there. Right on the bone. Shot. All right. He's got a lot of arthritis back here. Shot. I'm going to move down. He's not rotated, is he? Shot. Just want to feel around with the probe. Shot. He may be all right. I'm feeling bone right here. This feels like lateral mass. Yeah, as long as you can get him lined up good, that would be great, Jordan. Huh? Shot. 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 All right, I'm just trying to get my probe in exactly the right spot. Shot. So sorry, I'm a little bit focused right now as I'm working, but just hang out and watch for a few minutes. That's good there. You can see the metal down at C4. Shot. Shot. Almost as far south as I want to be to C4. Shot. 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 That's better. All right, that's one side down. A little pressure. Okay, I got it. We're going to go to the other side now. Shot. So I need to get, that's around C4. I need to get up a little higher. Shot. That's around C3. Hold on. Shot. That's perfect at C3. Go ahead. I'm going to put a little numbing medicine in there. Go. We'll make an incision. It's a 3 millimeter incision. And now I'll go back in with our plasma rhizotomy device, and I'm going to have to target these facet joints. Shot. It looks pretty good for C2, but I'm not down on the bone. You must be on the bone before you burn. Got to feel it. If you don't feel it, it's a problem. Shot. I mean, it's on the X-ray, it looks perfect. On the AP, and you're happy we're not rotated, right?
Yes, sir.
It looks pretty good. Shot. That's medial. I want to be a little bit more lateral. Shot. That's like perfect spot. We're trying to kill the medial branch of the dorsal ramus. Shot. Sorry, shot. That looks good. Shot. Burned us. Shot. Let me know when you're ready. Three, four, 5, 1.
Yes, sir.
Shot. Shot? No, we don't have any more num num. Sorry. Give me a little more sleepy sleepy. We're done with the num nums. Shot? We're almost done here. It's looking really good as far as we're hitting all the targets we want for the pain nerves. Alright, let's move south. We're done with his neck. So we'll put 2 staples there. Come south, 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 south. Come on, Jordan. Yeah. It's fine. Let's go. You want to do DLDR first?
We can, definitely, yeah.
Let's go lateral view.
Hey, Sarah, are you gonna change the pillows? No, we're fine. Are you guys good? You good?
All right. So just to confirm, we're doing left 4-5. Everyone agree? Okay. We're going to do his Deuk laser disc repair now at L4-5 on the left. Shot. Is that where we are right there? Shot. So it could be a little bit lower. Shot. Can you clean up L4-5? I don't know why I can't see it well. I think you're off on orbit. But everyone agrees, that's better. Everyone agrees that's L4-5, right?
Yes, sir.
Shot. Looking good. May want to start a little bit more lateral. Shot. That's nice. Shot. Look how arthritic those facets are. Shot. The key here is to touch the facets as you're going in and then slip around them. If you do that, you won't have any problems. You have to stay low in the foramen. Shot. AP. Looks perfect. Move your hand. Shot. 3, 4, 3, 4, 5. Stay there for a second. Shot. Num. We're going to do his DPR and his DLDR at the same time. Right? Talk about efficiency. Where is it? Here?
Yes, sir.
Poker. Shot. I'm aiming for the junction shot of the transverse process and the superior facet. Shot. It's literally right. Shot. Yeah, a little bit medial to where I am. Shot. I think I'm a little under. I am. And then there. Shot. That's better. So you can actually see where the shot, transverse process, and superior articular process meet. It's literally at the tip of that probe. His muscles contracted and it pulled me right off the spine. That should be it. Shot. 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 It's like right there. All right. That's good. Coker. Shot. Shot. You agree that's 4? Hand out. Shot. Once again, it's a perfect spot for the to burn the pain nerve at L4. Call that nerve the medial branch of the dorsal ramus. Shot. And then there's L5 right there. Shot. 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 Trying to get a little bit further south to the sacrum. Shot. There it is. That's the spot. Shot. Oh, it's perfect. Right, Jordan?
Yes, sir.
It's perfect. This should take away his facet pain. That's one side done. Lateral. So we literally did the entire L3-4, L4-5, L5-S1 facets with this little incision right here. You see that, Henry? Between the tips. Right there, 3 millimeters.
Yes, we do.
We've already completed his DPR. We're now getting ready to do his DLDR at L4-5. Shot.
We have a question.
Sure.
This comes from Teak on YouTube,
Yeah.
and they
Sure.
ask, what symptoms from patients indicate a rhizotomy is needed versus the DLDR? I hope one day I hope you give Dr. Berndes a mic as well. It's great hearing the communications.
Dr. Berndes, you want to hear from him, huh? You sure? AP. Dr. Berndes just does a lot of heavy breathing. Shot. Stay there. Louis? Yeah, Dr. Berndes should have a mic. I agree. He has a lot to add. Shot. Look at that tear. It went across the disc. Okay. Well, very good. We're going to start the Deuk laser disc repair on this side. And then we're going to do our DPR on the other side. How's the neck look? Looks good? The neck? I don't see anything. We didn't have any bleeding, but it's always good to look and see. Thanks. We will give Dr. Berndes a mic someday. I think he's earned it. Shot. All right, we're taking the needle out. We still have our guide wire. The guide wire is so important. The needle is so important. The dilator is so important. All these tools work together. And I remember when guide wires kind of came out for guiding surgeons back in the 90s. And they were phenomenal. The whole concept of a guide wire to guide the instrument safely through the body. Remember the first percutaneous pedicle screws we put in? We were doing it for Medtronic at UF Gainesville, where I trained. We were one of their sites for testing new technologies, and percutaneous screws were just coming out. Percutaneous pedicle screws. And we were putting them in using their sextant system, a little bit more, and shot, using the percutaneous sextant system. That disc is pretty tight. Remember, we used to use K-wires back then as our guide wires. Orthopedics does a lot of that stuff. Think we're in? Think we're in? Looks like we're in. Come on out. All right, fantastic. We're getting our DLDR done, and then we're going to go back for the end and do our right side DPR. Got it? Yeah, it's coming. I want to say kudos to my entire team, headed by Luis and Dr. Berndes, for getting everybody, all these surgeries done today. We'll be done by 6:30, which I think we're all worried we're going to be here till late. I'm laughing because 6:30 is late, but for neurosurgeons it's not late. You know, we used to be in the operating room till 10, 11 o'clock at night, and then the emergencies would start showing up, and we'd be doing those too, all night long. All night long operating. It was an experience at Shands Hospital. Grab her.
How was harder neurosurgery rotation at UCLA? Was harder than even transplant surgery?
Yeah, neurosurgery stuff. You did both, huh? Yeah. Dr. Berndes said when he was at UCLA, he did both transplant and neurosurgery. Transplant's notoriously hard. Transplant's crazy because you gotta, literally, somebody dies, they donate their organ, you gotta fly there in a plane with the surgeon. You gotta get there before the organ dies. You gotta explant it, and then you gotta put it back on the plane and fly back and then do the whole frickin' surgery. I mean, we had a guy who did transplants at Shands. He was just an incredible man. Honestly, Dr. Staples was his name. You know, this guy probably doesn't even know my name from Adam. But I admired the hell out of that man. I admired the hell out of that man. That is one of the most admired surgeons I've ever not even really met, because I never did transplant. I just knew about him. And that man, you would see him, he was skinny. He looked like death warmed over. Wore glasses, totally thin, just a total introvert. And I would get up there sometimes and I would see him sitting in the helicopter or the plane, and he'd just be sitting there solemnly. But every single time that he was needed, he showed up. And I think he was like the #1 transplant surgeon at Shands. And the dedication you have to have is beyond anything that I'm capable of. But it takes a very special human being to do that work.
I was an intern and I was scrubbed in with probably the #1 transplant surgeon in the world.
UCLA?
Yeah, he wrote all the textbooks. And I had a blind date with the hospital operator because she kept paging me. So I asked her on a date. And I asked him if I could borrow one of his Ferraris. There was dead silence in the operating room.
Really?
I heard an instrument drop.
I don't even think this guy, Dr. Staples, had a Ferrari. See, if I was a transplant surgeon, this is exactly how I would be. Dr. Deuk, we have a brain dead patient. They're willing to donate. We've got a liver here. Okay, great. What time will it, I would say, what time will it arrive? Or what time are you guys going to be ready for me? Oh, we're ready for you now. It's like 8 o'clock at night. I'd be like, wait a second. If I fly there, do the surgery and harvest the organ, and then fly back, I'll be operating all night long, right? I'd be like, no. I need to be operating when it's convenient for me. So let's not pull the plug yet. I'll be there tomorrow morning, right? I would be a terrible transplant surgeon. No, it's just dripping. I would be so bad. I'd be like, no, I'm having breakfast. Don't bother me right now. I know. There's never been a transplant surgeon to delay a case because I've never been a transplant surgeon. But if I was, I would be an elective transplant surgeon, right? I'm not coming in at 2 o'clock in the morning to do surgery. Hell no.
Well, you got to fly there first, then do the surgery, then come back.
I know, that's what I'm saying. It's like literally a 12-hour ordeal. And it's in the middle of the night because they have these talks at the hospital with the families about pulling the plug, in the evening. Like they think about it all day. People fly in. And finally they're ready to pull the plug and get that organ. And then, of course, they always put the transplants at night. Like everyone does their elective surgeries. And then once all the ORs are cleared out, 10 o'clock at night, 11 o'clock, that's when they start the transplant guy.
Then they're done around 5:30, and then just about time ready to start rounding. It's crazy. And then the rounding's unbelievable stuff that's going on the floor.
Oh, yeah.
I've never seen
Oh, my God. Managing a transplant patient with all those drugs and drips and holy crap. It's the hardest thing in medicine. No, that's why I had massive respect for Dr. Staples. Even though I never met him, everyone just knew he was the transplant surgeon at Shands. I don't even know if he's still alive. But man, that guy was dedicated to his job, to people. I wish I had that kind of dedication.
You do.
No, I don't.
You're just doing a different procedure.
He was amazing. No, but he was sleep deprived and life deprived and emotionally deprived. I mean, the man, he was a machine, like a robot. He was a robot. He was probably the first AI robot that did transplant surgery. We just don't know about it. I mean that in the highest way. He was never talked. I never heard the guy talk. And when he did talk, actually, I heard him talk once. It was so soft-spoken. Just the softest voice, like a whisper. Instructions to the nursing staff about where to set the drips and, dopamine, 3.5 mics. He knew everything. He knew all the drugs, where to set them, and he would just talk so softly you couldn't even hear him. It was incredible human, honestly. I forgot about him until we just started talking about it. What would the world be like without those unsung heroes? Honestly. He convinced me. I had thoughts of doing transplant surgery. He convinced me that I didn't have the mettle to do it. And he didn't even tell me anything. I'm sure he would have been happy to have me be a transplant surgeon. But just watching him, how he silently moved through the night.
What's crazy is that a neurosurgeon says they don't have the mettle to be a transplant surgeon. That shows you how hard.
That shows you how hard transplants are. I say that surgery is very surgeon dependent. It really is. There are neurosurgeons that are really fast, really good at what they do. And there are neurosurgeons that are horribly inefficient, slow, and do terrible surgery. And everything in between.
I've seen it all.
I don't know. Yeah, I know you have. I have too. I don't know how good Dr. Staples was, but I just know how dedicated he was. And they don't make people like that anymore. It's a shame. He's moving a bit. All right, any questions?
No current questions.
Well, Dr. Staples, you did inspire me. Even though I didn't become a transplant surgeon, I learned a lot from you about dedication, commitment, sacrifice. Never even operated with him once. I just knew of him. It's kind of like the Phantom of the Opera, you know, hiding in the wings. Nobody really knows about him or talks about him, but everyone kind of knows he exists. All right, so far this patient is doing well. We're not having any problems. He's got a lot of arthritis here at 4-5 on this side. I'm trying to clear out as much as I can. As I say all the time, we're never going to get it all. We need to get enough, and that's all we need. Just enough. We don't want to gild the lily. There's the nerve root. You guys see the nerve root right there, the bottom edge of it?
Yes,
We're
we do.
just underneath it. Let me get that piece of bone spur right there, and then we'll be done. And then we'll move on. We got 10 minutes. Get ready, Jordan. No, he doesn't like that. Look at the laser melt that spur away. Yeah, he's jiggling a little. You guys see that? Just total annihilation. So who thinks the bone spur had a chance? Good. 'Cause you're went well. Bring the scope in here, fluoroscope. So it's interesting, we call the fluoroscope a scope, we call the endoscope a scope, we call the microscope a scope. We have a lot of scopes. Right, Luis? We have a lot of scopes. Any questions, Henry?
No current questions.
Any viewers?
Yes, we actually got a few, good amount.
Oh. All right, well, the diehards, I love it. We are diehards as well. This is our last of 5 surgeries today. We should be done by 6:30 Eastern Standard Time. And we literally are just about finished. Yeah, shot. Let's go a little more to your side. Shot. All right. So we got, what do we got here? You think that's 3 below my needle?
Yes, sir.
I kind of agree. Shot. That should be 3 right about there. Yeah, I'm on it. Right? That looks like 3. Then we got 4 there. 5 is hard to see. Go ahead, Luis. Because of the contrast from the injection. All right, we have a little incision. And then I'm going to go in with our plasma rhizotomy device. And let's see where that is. Shot. Not bad. Pretty close. Shot. That's perfect. All right. So far, so good. This patient is doing really well. And I feel very optimistic for him. Shot. Shot. Shot? Shot? It's about as perfect as it gets. Any questions from our audience?
No current questions, but we
Sean?
do have a comment from Sherry on Facebook saying, I love watching you, so interesting and educational.
Oh, Sherry. Sherry, if you're from the 80s, you know who I'm singing from. The song Oh Sherry. Steve Perry, Oh Sherry. Hey, great to hear from you, and thank you. It means a lot to us. We enjoy showing what we do and teaching people, being available to answer questions. You know, we were talking about training earlier. Can you help me find the TP? It looks like it's there by the contrast, right? Kind of right superficial to that nerve root. Yeah, that's what I think too. I agree. So I got the idea to do this from my residency because in neurosurgery and other surgery, the way you learn is by going in the operating room. Let's do a second incision. You go into the operating room and you stand there and, like Luis, and you watch the surgeon do surgery. And so that's how I learned. That's how all the residents learn in this country and other countries, is by standing next to the surgeon and watching them operate. So I got this idea that, well, shoot, if that's how we're going to do it for the doctors, why not, you know, broadcast and teach the public the same way we teach doctors. I knew that was too low. Shot? That should be good, huh? That's perfect. Go ahead, do none.
We have a question.
Sure.
This comes from JMC on YouTube.
Yes, JMC. Happy to answer your question.
They asked, do you operate on Brandon patients with ankylosing spondylitis that have herniated discs?
Well, I got the ankylosing spondylitis. I got the herniated disc. The Brandon patients?
That's what it says, Brandon patients, like the name Brandon.
I don't know what that means.
I don't know what it means either.
I'll be honest, I'm not really sure what Brandon patients means. I don't know if he means new patients or I don't know. All I know is that I will operate on anybody where I can help them. And if they have ankylosing spondylitis and they have, you know, symptoms from a problem from ankylosing spondylitis, like a herniated disc, I'll do the surgery. Sure. I think it will help as long as I believe it will help the patient. So, yeah, patients with ankylosing spondylitis, they get bad discs too, you know, just like everybody else. Shot. And I can help those people for sure. Shot. That feels good to me. I feel like I'm on the TP there. Well, at least I did. Now I don't. Maybe right. I don't know. Shot. Once again, I will not start up my device to burn unless I'm sure of where I'm at. I have to be on the bone. That's very important, folks. Shot. What do you think? That looks pretty good, right? Yeah, I mean, I feel TP. I feel the transverse process. Shot.
We have another question.
Sure.
This comes from Michael on YouTube.
Michael?
And they asked, currently have a C6 through C7 herniation.
Shot.
I work in the tree removal business and currently out of work due to the amount of pain I am in. After having your laser surgery, how long would you say before I can go back to work?
Well, you're in the tree removal business. Let's get a better view on your side. I need you to pull the fluoro to your side. I got to see that bottom down there. I don't know what tree removal business means. I mean, to me, you could be a chainsawer, you could be a rig runner, you could be a, a stump grinder. I don't know what you do, but basically the restrictions after the surgery are that, it looks good, huh? What do you think? It feels good. Down, shot? I feel like there it is. Yeah. Let me just check it again. I moved it. Let me just check it again. Shot. That looks perfect. So basically, you can go back to work the next day as long as you're not heavy lifting. Huh? That's it. The last one. We're done. Yeah, as long as you're not lifting heavy things. Okay, shot? So the problem is that people that, go back to heavy lifting, bending, picking things up that are heavy, like 40 pounds or more, they're going to hurt themselves. And you don't want to do that because you're going to be back again for another surgery. Good job today.
Nice one, please.
Thank you, everybody. Great work. We got a lot done. But yeah, I would say you can go back to work. Literally, you come here 3 days, you leave the third day, go home. So if you're here like Monday, Tuesday, Wednesday, fly home Wednesday, wherever you live, and then you can go back to work the next day or the day after. But you can't be picking up anything heavy, okay? You got to give your discs time to heal, otherwise you'll re-herniate them. I'd say 25 pounds maximum. But listen, it's the best surgery for you. You got to take time to get your body to heal. If you don't heal that disc properly, then it's going to plague you the rest of your life. And if you go get a fusion, then it's going to wear down other discs. You're going to be back again for more fusions. You're going to have scar tissue, stiff neck, trouble swallowing, hoarseness, all the complications, pain management. Do it right. Get the Deuk laser disc repair. Let it heal properly, and then enjoy the rest of your life without any problems. Great question. All right, we're going to end the broadcast because it's been a long day for everybody, and we want to wrap this up. We'll see you all next week. I'm going to call blood loss 1 mil.